So welcome back to the third annual Virtual Diabetes Symposium, and welcome to those of you who are attending for the first time today. Thank you so much for being here. We have another two wonderful speakers on with us this evening, but before I let them get going, I have some housekeeping for us. So this event is hosted by the Delaware Diabetes Coalition. Our executive director is Sarah Bloom, and I am the current president, Kimmie Moore. So just a little background on who we are. So we are the Delaware Diabetes Coalition, a statewide nonprofit organization comprised of a network of healthcare organizations working together to improve the lives of all people in Delaware affected by diabetes through awareness, prevention, identification, dissemination of services, and advocacy. I want to remind or inform everybody about the college scholarship that is offered by the Delaware Diabetes Coalition. It's a scholarship to provide financial assistance to a high school senior who are planning to attend further education in an accredited higher education program, or students currently enrolled in an undergraduate program who have type 1 or type 2 diabetes. Listed is some additional eligibility for students who are interested in applying. They need to be a Delaware resident, have at least a GPA of 3.0 or better. It is requiring a transcript. We do ask for a 500-word essay entitled "How Diabetes Has Impacted My Life Choices," 2 letters of support from non-family members, and they need to be able to make an appearance or submit a video to be played at the annual Delaware Diabetes Wellness Expo held in November. And this can only be a one-time recipient. The award is for $1,000. The deadline to apply is April 30th. And you can email submissions to Sarah at director@dediabetescoalition.org. So you can receive continuing education credits for this evening. To do that, you need to complete the 120-minute webinar live, so attend the whole time. We'll be sending out an evaluation at the end that needs to be completed by February 28th. Again, this is approved for 2 contact hours through the American Nurses Credentialing Center, Commission on Dietetic Registration, and the Certification Board for Diabetes Care and Education. And you can find the speaker and planner disclosures on the Delaware Diabetes Coalition website. Our learning outcome for this evening is that attendees will report an increased knowledge of the physical aspects of youth and diabetes, how to advocate for 504 accommodations for students, and current diabetes technology to better support and care for children and teens with diabetes in a school setting. And so with that, I am going to stop sharing my screen and allow Megan to share hers, and I will introduce our next speaker. I need to double check that I have you able to. Here you go. You should be able to share now. Are you able to share your screen, Megan?
Yes, I think so.
Wonderful.
Look it up there.
I can see you. So I will introduce you before I let you get started. We can see your screen perfectly. So Megan Dougherty has a degree in human services from the University of Delaware and joined the JDRF staff in 2019. Megan is currently the Community Engagement Manager for the Greater Delaware Valley chapter of JDRF. She works with the local type 1 diabetes community and local healthcare systems to help provide information/resources, as well as managing/planning local outreach events hosted by the chapter in person and virtually. Megan has been a part of the type 1 diabetes community after her type 1 diabetes diagnosis in 1998 as a child. And with that, Megan, thank you for being here, and take it away.
All right, great. Thank you so much. Thank you so much for having me this evening. As Kimmie said, my name is Megan Dougherty. I am the Greater Delaware Valley Chapter Community Engagement Manager. It is so nice to have you all here tonight. So welcome. I'm here to tell you the ways that JDRF connects to our type 1 diabetes community through all the different stages and ages of type 1 diabetes. And just kind of getting through some of our resources and some helpful things that'll help your students, help any family members you know, anyone you know with diabetes. Throughout this presentation, we will highlight the ways that JDRF can support you and your students and help you all find a network of people living with type 1 that will help support these families that you're working with, your students, and keep things ongoing for education and any resources you might need.
Megan, before you go, your camera's not on if you did want to.
Oh,
someone type that in the chat.
I didn't even know if you could see me or not, so that is fine. Hi, this is me. Hello, everyone. So this is my DDC disclosure here, just making sure we're putting that up on the screen for everybody. Kimmie, I don't believe I have to read this, so I'll let y'all take a moment and look it over. Then I'm going to move on. All right, so our story, just so quickly, so JDRF was formed about 50 years ago. We are the founding chapter of JDRF here in the Greater Delaware Valley. So this chapter was formed by two moms coming together and wanting to share their passion and support for not only their type 1 children, but all the children that they knew that were out there with type 1. Since then, 50 years later, JDRF has played a role in virtually every transformative change in type 1 care. So I will talk you through some of those things. That black and white photo, though, that you see there, those are the two moms that started our founding chapter here. So I always like to throw that in, that it started over on the East Coast. All right. So what is our vision? Our vision is a world without type 1 diabetes. And we are looking to find that vision through our mission. And that is improving lives today, tomorrow, by accelerating life-changing breakthroughs to cure, to treat, and prevent type 1 diabetes and its complications. So as Kimmie mentioned, I am type 1. I have been for quite some time. So JDRF has been a part of my life for quite a while, but it's really interesting on the work side of things to see how it really supports you all. So since our founding, we've stayed true to our mission to fund those life-changing resources and one day cure type 1 diabetes. We also know that those impacted by T1D today need better outcomes, need support, and need an option to lessen the burden of type 1 diabetes and its management. We work to support all of our families, and that really includes improving lives for those living with diabetes today. So we will talk through in depth about the ways that JDRF is working to build our community, strengthen the knowledge of those living with type 1, and making sure that all impacted by diabetes have the same resources, access, and support to the amazing treatments and care that we have out there today. All right, so what do we get to do? So we support our community through, I always say, all different stages, ages, and ranges of type 1. So we are offering different lifestyle supports. We strive to offer opportunities that are as diverse as those living with type 1 diabetes. You're going to get to see and hear some of our options that we can ship to folks' homes, some options that we have for you to use in your offices or share with your families, other ways to volunteer or to get folks interacted with JDRF and the type 1 community. So we want to offer as many options as possible to those living with type 1 diabetes and to have the best up-to-date information. So for the last year and a half, our chapter has helped provide 317 Bag of Hope resources, 90 teen care kit resources, and 48 adult care kit resources. I will go into what those look like, but just gives you an idea of kind of the numbers that we are hitting with some of our resources that we can ship home to people. And those resources, they offer comfort at diagnosis and ongoing information that's aimed to making life with type 1 more manageable at every age and at every stage. So, a T1D diagnosis changes the family. We all know that. It doesn't just change that individual living with type 1. It changes every aspect. So what do? How do we help with that? We offer, like I said, lots of resources, but also just positive hope that you're going to be okay. So these are awesome Bag of Hope kits and teen care resources that I was speaking on earlier. So you will see from left to right, these are our resources for newly diagnosed individuals. I have included some QR codes on our screen here. So anyone at home, if you're interested in finding our websites that will link you to these resources, you can certainly use these QR codes to do so. So nationally, JDRF reaches approximately 14,000 newly diagnosed families and adults throughout each year. On the far left is our Bag of Hope. This is a free resource that we provide for children under the age of 12 that are newly diagnosed with type 1 diabetes. This resource is available in English as well as Spanish. So this bag has a lot of great stuff in it. Some of you may have seen or heard of Rufus the bear with diabetes. This is where you get him, from our Bag of Hope. And I'll get into him a little bit more, but he does have an app now, and he makes learning and educating kids that have diabetes, he makes it a lot more friendly, a lot more fun, a lot more interactable. This bag also contains our Begin with Hope guide, as well as some great books for little kids that will really walk them through their type 1 diagnosis in stories and words that make sense to their age range. On the far right, you'll see our No Limits Teen Care Kit, and that is for our tweens and our teens, so ages about 12 to 17. We do have this option available in English as well as Spanish resources. The Spanish resources are something that we just added within the last 6 months or so to our program, and we're really, really excited to be able to provide those resources. So this one will arrive in a box, and you will get anything you see there. So the stickers are personally my favorite part, but we do have some really great books that help those kind of younger adults get to know their type 1 diagnosis a little bit better. Then we also have a fun little bag that they can store all their needed diabetes supplies in. Not shown here, but we do have a No Limits adult care kit as well. So for anybody over the age of 18, this is a free resource again. Very similar to our teen care kit, though I don't believe it includes the stickers, but it is a great resource for adults who are diagnosed with diabetes. So all 3 of these resources were thoughtfully and carefully planned out, and they're used to support newly diagnosed families and individuals with the information that they need to start their T1D journey. This resource, though, it's more than a box or a bag of goodies filled with things. It's showing them there's a community out here. JDRF is here. There are other folks like you who are dealing with this every day, and you're not alone. So we really hope that this gets folks to see that there is a network out there. There are other people around here in your community. Again, these are provided at no cost. So these are free for folks to order via our website through that link there, or a lot of folks will get them when they are newly diagnosed within their hospital. So working with their different healthcare partners. All right, I'll go through this real quick, but this is Rufus and his app. So if you haven't heard of Rufus, he is the bear with type 1 diabetes. He's a really great resource for our younger kiddos who are diagnosed with type 1, kind of making them feel like they have a buddy who has type 1 with them. And I remember getting Rufus when I was a little kid back when I was diagnosed, but now he has an app, which he didn't have before. And it's really great because he has different patches on him that are scannable for kiddos to use within the app, and it helps them test Rufus's blood sugar. It helps them dose insulin on Rufus or count carbs. What carbs are Rufus eating? So it's a really great educational piece to help out our younger folks with type 1. All right, so what else? We know that type 1 diabetes affects all kinds of people at all stages of life. We have developed resources to support folks in many ways as possible and strive to continue to add to our toolbox. So these items you'll see listed here, the wording in blue, those are kind of the titles to the activities that our national team provides virtually. So for right now, for English speakers, you'll see the first one listed is our Type 1 Nation. So these are all virtual resources provided via Zoom, Facebook Live, YouTube, Twitter, kind of all different ways. And I will kind of let you read what those are about here. But again, these summit series or these no limit speaker series, they are all for our type 1 diabetes community in any different stage, range, or age. So we have certain calls just addressing to caregivers or grandparents. We have some for school nurses. We have some that are focused just on women's health, just on men's health. So there definitely are a different array of topics and activities that each of them go into. So they're really great to check out. All of these are free as well. The last one you'll see listed, that is we are affiliated with Beyond Type 1. They are a great organization, so we work with them to offer these community roundtable talks as well. They are the last Thursdays of the month and a really great resource for, again, kind of any range, age, or stage. All right, so this is an event really near and dear to my heart. Again, this is a free event. We try to make things as easy and accessible for our folks in the community. So this is our Type 1 Nation Summit, and this event is in person. So our local chapter and all of our local chapters of JDRF host in-person Type 1 Nation summits for families and individuals to come on out and experience a day of education, getting to meet and connect with the Type 1 diabetes community, and as well as getting to interact with some of our leading partners in a vendor fair. So our Type 1 Nation Summit is a really great resource to families and educators, anyone who's really looking to learn more about the Type 1 community or educate themselves on all the exciting technology updates. We have some sessions on mindfulness and mental health and type 1 diabetes. So there's kind of an array of different sessions that we'll be offering at our summits and that are offered throughout our different chapter summits as well. So that QR code, that'll take you to our site if you're interested in sharing that with anybody or checking it on out. Our local summit for this chapter will be held at Westchester University on March 19th. And again, this is offered virtually through our national staff. So if you go back to that slide I was just on there, that is online, and this is our option in person. So we're trying to meet people as best as we can. We also know that there has been a rise in the Spanish-speaking community and type 1 diabetes diagnosis. So we saw that, and we really wanted to make sure that we are providing resources to anyone who has type 1 diabetes. We all know it doesn't discriminate. So JDRF launched our T1D resources for Spanish-speaking families on our website. Again, there's that QR code if you're looking to grab that, but it has many different options for you to choose from. So those summits I was just speaking about, we do offer summits available in Spanish as well, and they do focus on some different topics. But this was very important to us as we continue to grow as an organization. We want to make sure that our resources are growing with our community as well. And again, this is just kind of an easy place to find those virtual education sites or anything you're looking for community-based wise. Virtually, these two codes will take you there. But throughout COVID, we learned the value of virtual education, which I know is very familiar to you all on this call. So we wanted to make sure that we had this option anytime, even now that we're slowly coming out of our COVID scares. But we have seen an increase in participation from people living in rural areas that we haven't quite seen before. So virtual it's exciting for us. We're really getting to connect with a lot of different families and meet them where they are. You always have your phone. So even if you're stuck in traffic, you can definitely pop us through your speakers and we'll be there sharing our virtual resources with you. We also have this great support online. This is our online diabetes support team. So this is made up of compassionate volunteers who know firsthand the ever-changing demands of living with type 1. So our ODST volunteers, they do their best to respond as quickly as they can, though they are not medical or legal professionals, but they certainly can provide helpful resources quickly, as well as just being a great kind of shoulder to be there and someone to listen. And I always say, type 1 families, we speak a different language. So these folks, they talk that talk, and it's always great to be able to know that someone is just a phone call away. So the important stuff for you guys, how can we use these JDRF resources in schools and the workplace? So JDRF school resources not only support our families and individuals and kids and young adults that are impacted by that type 1 diabetes diagnosis, but we also offer education and guidance for teachers and school staff. So we have an array of different resources on our website that you'll find. Again, that QR code will take you right to our school-based resources. So we have great guides on everything covering 504 plans, IEP plans, how to support children with type 1. It even has resources for families sending their children off to college or to live independently for the first time. We know that's always a scary move no matter what. And we also try to plan some virtual summits and education events around the back to school topics. So certainly you'll see those in the later summer, early fall months. This again are some really great visuals of those resources we have for taking T1D to school or talking T1D in school, because we found that folks are really succeeding when they have the information and they can see these things. So we want to continue to offer meaningful content and ensure that it's delivered in an impactful way for as many folks as possible. So we try to make these as easy to digest as we can. You will see some graphics, numbers. It's not just kind of science talk. So it is something that younger kiddos can look on to, or even folks who are not quite part of the maybe healthcare team at your school. Very easy to digest. So these are all available on our website, and parents and school staff can certainly print these out, have them on hand, have them to display, whatever you see fit. This slide gets into our health insurance guide that we have. We know that having health insurance is critical in helping manage and treat your type 1 diabetes. So we want to make sure that our folks know what they have access to. We aim to help our families understand their coverage plans, understand the insurance process, including denials and prior authorization, learn the vocabulary included in pharmacy coverage, and then offering guidance on what to do if there is a loss of coverage or a change in your current status. So this is a really, really great resource to provide to any families you know who are in need. The second or the bottom QR code that you'll see, that will take you to Beyond Type 1 and take you to getinsulin.org. This is a really, really great free resource that helps those who are struggling with insulin access and affordability. So this will help those folks find access to our insulin. Again, these are some more kind of helpful resources that we have as we understand that sometimes families and individuals need more information about things that are not just how to check your blood sugar, what types of pumps out there, but how to exercise and avoid lows, burnout, how to talk about how insulin works, eating disorders and type 1 diabetes, mental health aspects of type 1 diabetes. So we know that folks need information on anything that they can find. So we have those here on our website. We also have the ability to help people know if they are at a higher risk to developing type 1 diabetes. And that is with one of our new resources. So we have resources for those living with type 1, but now we have the ability to help folks know if they're at a higher risk for developing type 1 diabetes with our new T1D screening and education program called T1 Detect. So again, you can use that QR code to check out T1 Detect. This is a very new aspect to our website that we are so excited about. This allows families and adults to access at-home blood tests to see if they carry the antibodies that are related to a type 1 diagnosis. So this test detects antibodies in your blood along with additional testing, and it may mean you are at risk for type 1 diabetes. So we know that there are rates just growing among ethnic groups, among Hispanic youth. We are seeing these numbers just rise and rise. And a lot of folks are getting misdiagnosed or diagnosed too late in life. And we are really striving to stop that from happening. So these tests are great. They are available to order. For $55, they will send you a test. It's an easy finger prick and very painless. And you will receive your antibody results and explanations of what they mean and the next steps on what to do with all these test results that you have. So again, this is a really great resource to provide to families or anybody that you may know that has a loved one or someone close to them with type 1. It's always great to get those around you tested. All right. So JDRF also offers those impacted with T1D the opportunity to turn their diagnosis into action and to help change their future through supporting life-changing research. I cannot speak today, guys. I apologize. So this slide shows you some of our local outreach events. These are all great things that we have coming up. Again, this QR, that will take you to our local website that'll show you all of our events. Most of our events here at the chapter are free for families. We do have certain ones that are ticketed. So you might notice that JDRF Night at the Philly Phillies, you would have to buy a Philly ticket to attend that night. But again, our Type 1 Nation Summit, free event. We have a great summer series event, which is an outreach-based program where we're just meeting families in the park and getting them to connect with each other and interact with each other. And just again, know that there are folks out there like them. They are not at this alone. It is a community. We also offer virtual meetups, which is a really, really big piece of our chapter here. So this is kind of towards the bottom in white. We offer those virtual meetups for any ages, ranges, and stages of T1D. So we have calls for our younger kiddos, our kids 5 to 10. We have calls for our teens and our tweens. We have calls for adults, and then those for parents and caregivers as well. These are really great calls that just lend to some support. And again, just getting folks to know that they are not alone within this community. And there's folks maybe even in their neighborhood or go to their school that have Type 1 as well. We are big fundraisers here. That is how we help fund all these great different things that we're working on. So all the new pumps that are coming out, the Dexcom 7, all the new exciting updates that you're seeing, we help provide money for these things through our fundraising efforts, as well as our advocacy efforts. So again, this is why the CGM is possible. The closed loop systems are a reality, and the cure is going to be found. So we have some great programs. We have a walk program. We've got a bicycle riding program, galas, all kinds of different stuff. And again, we always encourage folks to become an advocate for JDRF. It is free to do so, but we use our advocates to push insulin affordability, to reach out to their local lawmakers and those in the Senate to really just push for our Type 1 diabetes rights and making sure that people know that we're out there and we matter and we should be supported. Well, that is it for me. But thank you so much for your time today and just for all the help that you provide to the Type 1 community. I know you all work really hard and do a lot of work on your day-to-day. And just know, as someone who was a young kiddo in the Delaware school system her whole life, you very much have done a lot for me and my family. And I know a lot of the kiddos that you're supporting right now. I want you to know that we are here to support you and your families and the kids that you work with and the individuals that you help out. We want to help them be more connected, to be educated, and just have a positive outcome on their Type 1 and their lives. So I look forward to helping any of you who are interested or connecting you with some programs or some great resources in our area. But again, my name is Megan Dougherty. I'm the Community Engagement Manager for JDRF and the Greater Delaware Valley Chapter. And I thank you so much for your time.
Great, thank you so much, Megan. And I am going to open it up for questions. I don't see any currently in the Q&A. I did have a great comment come through to, and I should mention this anyway, that as far as your resource list goes, that we do with the Delaware Diabetes Coalition have an emergency fund that we would love added to that resource list. And we can, of course, provide you more information on that.
Perfect. Yeah, let's do it.
Great. Any other questions for anybody? I know I'll just say thank you so much for sharing all of these resources. It's always great to just see really easily accessible things that are right at our hands, most of them free, events that are mostly free. That was really awesome. So thank you so much for sharing.
Of course. Thanks for having me.
Something in the Q&A. Lots of thank yous, and thank you for being so upbeat and positive and sharing all of this with all the that you're willing to help with all the challenges folks with Type 1 diabetes are facing. So lots of thank yous, and thank you for the wonderful resources.
Great. Thank you all.
Such a great presentation. No questions, but compliments rolling in for you, Megan.
All right, I'll take it.
Just a couple more minutes just to see if anybody's typing out a long one.
Totally.
Here's a question for you. Are the QR codes on the website? Any of these QR codes for the other links?
So actually all those QR codes will take you to different points of our website. So any of those should be JDRF website based. One will take you to getinsulin.org, which is the Beyond Type 1 resource there. But yes, these QR codes will take you to the JDRF website. I don't know, Kimmie, if there's a good way to share that with folks, or if you type in jdrf.org, it'll take you right there.
Yes. And so we'll actually be, and thank you for saying that. Sometimes I read the questions and don't fully process. Yeah, so we will be sending out the PowerPoints.
Perfect.
The facts. So those QR codes will be on the PowerPoint for you to be able to easily access any of those websites.
Beautiful.
Thanks for putting that light bulb on for me, Megan.
Yeah, no worries.
I see a couple more. No, and a few more really thank yous for your really informative presentation.
Okay.
Well, with that, Kimmie, are you ready to go? I don't get to introduce many other Kimmies, so that's exciting for me. I'll give her a few minutes. Oh,
Yep, I'm here. I will be good to go. I just need to bring things up and I'm set to go.
wonderful. So Megan, thank you so much. You are welcome to stay on and listen to our next presentation. We do just ask that you mute and turn your camera off for our next presentation, but we would love for you to stick around.
You got it.
Thank you. Thank you so much. I say round of applause. And Kimmie, you are welcome to share your screen. I should be you should be able to. Perfect.
Can you see?
Yep, you're still in slide mode. You're not in presentation mode.
Right.
And
Yes. Okay.
wonderful. Let me get you introduced so everyone knows who's up next. So next up, we have Kimmie Shoe. Kimmie is a nurse practitioner and diabetes educator working at Nemours Children's Health Endocrinology since 2004. She's obtained her BSN from Penn State University and her MSN from Thomas Jefferson. She enjoys taking care of patients with type 1 diabetes, and through her years at Nemours has become supervisor to the wonderful nurses and nurse practitioners in her department. She has had type 1 diabetes since she was 5 years old. It's her passion to enlighten, guide, and inspire children to live their best lives with type 1 diabetes. She has been the exercise resource within her department, and she is proud to say that she is currently training for her second qualified Boston Marathon this April. It'll be her 25th marathon, and she is more stable now with all the diabetes advancements that have been approved over the year. With that, thank you so much, Kimmie. I'll hand it over to you.
Thank you. I know we're getting started a little bit early here, and part of me was worried about how much I had squished into the presentation, but I'm happy to get started and go as long as we need to. Thank you for the invitation to speak tonight, and we will dive in. I'm going to go through a little bit, a decent amount of stuff on diabetes, type 1, type 2, and some of the technology. So stick with me. If there's questions, you can let me know, or we'll wait till the end to address. My disclosure, as you see on the screen in front of you, no relevant financial relationships to anything that I'm speaking on tonight. Thank you for that. And so the objectives here tonight, we're going to talk a little bit about type 1 diabetes, the pathophysiology and management. We'll discuss low blood sugar, and high blood sugar, ketones that comes with significant hyperglycemia. We'll then touch on a little bit about type 2 diabetes because of the way in which it has increased in our children, in our pediatric population, and some of the new management strategies. There will be a show and tell about continuous glucose monitors, as well as insulin pumps, and reviewing some of the data that we see on insulin pumps and continuous glucose monitors when we see patients at clinic at Nemours. And then a little bit about at-risk patients, which I saw very much, or at the end, that was mentioned by Megan about the at-risk population of patients with diabetes some concerns. So type 1 diabetes, I'm under the impression most everybody here understands kind of what it is, what insulin is, and how it works. This slide is a great demonstration of how insulin works by allowing food that's eaten to be properly digested and the sugars and the glucose molecules to get inside of the cells to provide energy. The insulin is the key that opens the door and lets the sugars inside out of the bloodstream, lowering the blood sugar and providing the energy needed for metabolism. Without insulin, the glucose channels are locked and the cells either die off or resort to muscle and fat stores in the body that then turn into an acidotic byproduct that's concerning and leads to either new onset of type 1 diabetes or diabetic ketoacidosis. In type 1 diabetes, we know that insulin is the only hormone available that lowers blood sugar. Every other hormone in the body will raise it. If not a little bit, it'll be a significant amount depending upon what's going on. So the other hormones that we work with in endocrinology include the glucagon hormone, the rescue of the liver breaking down glucose to fix low blood sugars, cortisol for waking and the regular metabolism needs of the body for energy, growth hormone for growth, development, maintenance levels, and exacerbated levels during pubertal times, adrenaline, epinephrine, the estrogen and testosterone of puberty, and what our kiddos go through as they mature. Exercise can also lower blood sugars, but in a different fashion because exercise will increase the sensitivity and the muscles are utilizing the glucose molecules more with the contraction. And so it absorbs the glucose better, it gets it out of the bloodstream and can cause lower blood sugars, but not without the assistance of insulin. So looking and discussing new onset type 1 diabetes, presenting symptoms, things we see in kiddos, whether they're coming into the pediatrician's office, you see them at school, there's some distractions, something going on with their focusing, going to the bathroom more often, tired, sluggish, different level of attention at school. We call them the polys, polydipsia, polyphagia, polyuria, the sudden extreme thirst, hunger, and urination. Wetting the bed suddenly, a change in the way the children are drinking, sleeping through the night. We see the sudden weight loss, drowsiness, fatigue, weight loss that looks like maybe they're getting taller and they're growing, but then all of a sudden their body loses the weight as they get taller and grow. And so it's hard to sometimes pinpoint what exactly is going on, but we know with type 1 diabetes, it could even stunt height as well as the weight. When it gets to a really critical state and they become acidotic with ketones, there is the fruity acetone smell or taste to the breath. There could be heavy labored breathing, the Kussmaul respirations, which leads to diabetic ketoacidosis and the need to get them in for IV fluids and careful, slow hydration. These symptoms of the new onset of type 1 diabetes can be the same or also identified in those with uncontrolled type 1 diabetes, having a ketone episode, missing a dose of insulin, insulin pump malfunction. They can all have similar types of symptoms. So management of insulin. So I have here the slide of Dr. Frederick Banting and Charles Best. To this day, I love the technology and the way things have evolved with diabetes management, insulin, all of it has come through the years. So I love to show where we started with this back in 1921 when insulin was finally first discovered and injected to help with diabetes in the dog, and then given to the first boy and girl, to a 14-year-old boy that had diabetes who was near death and very, very critically low weight. And we got to see him gain his weight and stop with the increased thirst, urination, and the amazing stuff that which insulin has provided. We know that insulin is a storage hormone. It helps our bodies to hold on to our muscle stores or fat stores, hold on to our food and have normal metabolism. Not specifically gain weight, but hold on to the weight that we need based on healthy eating and exercise. Insulin will inhibit or prevent catabolism or the breakdown of cells and complex molecules. It's the only one that lowers blood sugar. We dose it. This is not likely something you need to know, but we dose it in different increments depending upon the age, body weight, and pubertal status of boys and girls when we diagnose them. And then they use a certain amount of insulin depending upon whether or not they're honeymooning or not. Honeymooning is when the pancreas is still making a little bit of insulin to help with the body's needs, but not enough. So insulin injections must be given. So I have the dose guidelines of how much children use based on their age, whether they're newly diagnosed, complete diabetes and no longer honeymooning, or in puberty, no longer a school-age child, but adolescents, using maybe their body weight of insulin a day. So a unit of insulin per kilogram of weight a day. It just depends on their age and stage. We do start kids at Nemours on insulin injections first, and then depending upon their interests and what's working well for them as in their care, we can consider insulin pump therapy, which has come a long way. Different types of insulins. We are so lucky to finally have other types of insulins available, both generic of the basal bolus types of insulins and the brand names, which is great to have options now for insurance coverage. The rapid acting insulins, we have the Lispro, Novolog, Aspart, Apidra, Fiasp, Humalog, Novolog. They all start to work within 10 minutes, 10 to 30 minutes of injecting. We do prefer that insulin injections are given before meals, which is super hard for some of these kiddos that don't know what they want to eat or are confused, or the little guys, the 3-year-olds, 2-year-olds that might not finish what's on their plate. But we have to find a balance for how to get the insulin in early safely, whether that's 2 shots, a little before, a little after, an insulin pump, or what we do. We know that the rapid acting insulin peaks or works its best in about 1.5 to 2 hours. And then within 3 to 4 hours leaves the body. The fast acting insulins are given for food and corrections, fixing high blood sugars, bringing them down, and for any carbohydrates eaten. The long-acting insulins, Lantus, Levemir, Basaglar, Tresiba, Semglee, we have definite fancy names and new types of long-acting insulins. It used to just be the old and true Lantus, so it's great to have other options available. They are given once a day, almost always, and they last for about 24 hours, give or take. Peakless, they work consistently until they're gone within the 24-hour time period. And they kick in and start to work within an hour, hour and a half of injection, give or take. Tresiba is special. Tresiba is a longer acting insulin that usually lasts in the body about 42 hours. It's still given once a day. And it gets into a steady state within a couple of days of beginning this medication. When you give it daily, it works very well, a little more powerful or potent, so to say. But the nice thing is, because it lasts longer and it does not stack up to lead to hypoglycemia when given daily, if it's missed or forgotten, it might help protect somebody against ketones or really awful hyperglycemia. So we have tried this or trialed it a little bit in kids that might have trouble remembering their insulin injections over the weekend or miss it in the evenings every now and again. We might have them get their Tresiba at school by the nurse, or it helps them to remain a little bit more steady over the weekend should it be missed. It's good to have options. Okay, so this slide reviews the insulin management that we do at Nemours, where we are covering carbohydrates eaten and corrections for high blood sugars with the rapid acting insulin. The basal insulin via injections, we usually dose as about 0.4 units of insulin per kilo of weight a day for the school age kiddos, and maybe closer to 0.2 units of insulin per kilo of weight a day for a toddler, someone up to approximately age 5 years of age. It's all trial and error. It's all reviewing blood sugar values and seeing how things look. And we know that the long-acting insulin is dosed once a day. So the rest of the insulin is going to come from the rapid-acting insulin. And we determine, using some formulas and guidelines, where to start with the ratio for food and a correction formula for hyperglycemia corrections. The ratio here we have is 1 unit of insulin, rapid acting insulin, for every X grams of carbohydrates. So the examples on the right of my screen show that for maybe a toddler, it might be 1 unit of Humalog for every 60 grams of carbohydrate. And 60 grams of carbohydrate, like that's a decent amount for a toddler. It all depends on what we're talking about, but they might only have 30 or 40 grams of carbohydrate at a meal. So they would end up getting 40 carbs divided by the ratio of 60, it would be less than 1 unit of insulin because they're so sensitive and they're so small. Whereas the school-age child or the teenager at the bottom might have an insulin to carb ratio of 1 unit per 7 carbs or 10 carbs. So for every 10 carbs, 1 unit of insulin. So a 30-gram apple, a nice sized apple, would be 3 units of insulin possibly for the adolescent, whereas it would be half a unit of insulin for somebody who's a toddler, a 3-year-old. The correction formula tells us how much insulin is needed to lower high blood sugar values. Back in the day, it could be used as a sliding scale where we say 1 unit of Humalog for blood sugars between 100 and 150. And then if we're 150 to 200, take 2 extra units of Humalog. But with the correction formula, we can get more specific about how to fix those highs down to tenths and hundredths of a unit, rounding up or down, or our insulin pumps will give exactly what the dose calculates to be. So the sensitivity for these, or how much 1 unit of insulin will lower the blood sugar, varies based on the age and pubertal level of our kiddos. And the examples again on the side, correcting down to a target possibly of 150 for a toddler. We might pick 120 or 150 depending upon many factors. If they have a glucose monitor, are we safe and feel comfortable lowering them the whole way to 100 or 120? So the example for the toddler says high blood sugar value minus 150, the target, divided by a sensitivity factor of 150. So that means that 1 unit of Humalog could technically drop the blood sugar 150 points. That's not a lot of insulin. When you go to the bottom and you look at the teenager's correction formula example, it says high blood sugar minus 100, the target blood sugar of 100, because hopefully they're older, more sensitive to lows, can feel them, and divide by a sensitivity of 30. So for every 30 points, the blood sugar is 1 unit of insulin will lower the blood sugar about 30 points. So more correction insulin. This is a lot to learn, right? This is a lot of math, a lot of calculations, a lot of guessing. Always has to happen every day, every meal, every time that we look at the blood sugar value, we have to assess all of these factors. So it's very stressful for all parents and all family members. It's the dip into a whole bunch of confusion and guessing and rhyme or reason. We know how to treat, but there's so much of life that happens that can alter how we execute our decision making. So hypoglycemia, low blood sugars. The symptoms are on the side of the screen over there that are very common to low blood sugars. It also could be similar to anxiety, being fearful or scared about something. Some of these signs or symptoms for some of these teenagers or kids in college could go along with drinking or possibly even taking drugs. So we have to be very careful about the signs and symptoms of low blood sugars and how each child or even adult recognizes the symptoms, where their values are, depending upon what's going on in their life. Reasons for low blood sugars usually has to do with taking too much insulin, but that could be because of exercise. It could be that we didn't finish the food we dosed for. The lows could be because the insulin injection happened to be given into muscle instead of fat. Hopefully that doesn't happen these days with the teeny tiny little pen needles. Hot tubs and hot showers. The warm water can help to speed up insulin absorption if you just injected. So we often tell kiddos to wait a little bit before they get in the tub or the sauna or hot tub or something. Maybe just needing dose changes. Low blood sugars could be that we just need less insulin for some reason. So we have to adjust the ratio or the correction factor. Or honeymooning in the very beginning stages of diabetes. It could be the honeymoon. The rule of 15. So we're teaching this at Nemours, and it's a very common way of fixing our low blood sugars. If less than 70, we say to treat with 15 grams of fast-acting carbohydrates. And hopefully we all understand that fast-acting carbohydrates would be something like juice, orange juice, apple juice, Skittles, gummies, a little pack of fruit snacks, not the Twizzler, or not the Twix, not the Milky Way. It won't be M&Ms, because the M&M has fat in it and it's going to slow the absorption of the carbs that are in them. So we want to go with something that's going to quickly fix the blood sugar. Wait about 15 minutes after eating the 15 carbs and hope to see that when you recheck the sugar or relook at the CGM value, the glucose value, it has come up over 70. This gets tweaked a little bit for kids or young adults using an integrated insulin pump, where the insulin pump works together with the continuous glucose monitor and already backs down a little bit with the background insulin to protect from the low that was coming. In that instance, the kids might need less carbs to fix the low blood sugar because the pump was already trying to work in the background on its own. And we review that when we start kids on our pumps. Severe hypoglycemia, one thing that we hope never happens, but we have to teach and educate on for protection and safety. Severe hypoglycemia, blood sugars get so low that we either pass out, we're very confused, sweating, seizing. It could be at a blood sugar of 20, 30. It could be a blood sugar of 50. It's hard to say. Just because we've had a blood sugar of 39 once and was still okay doesn't mean that the next time we get to 42, we won't be completely confused and not making sense, as our brain shuts down to protect energy for the rest of the body and allow it to live while we get through this hypoglycemic episode. So I can never give you an exact number for when somebody will have a seizure or be so confused that you really have to talk them through what to do or how to fix the low or inject glucagon. So glucagon medication is the crash cart med that fixes lows by telling the liver to break down glucose and spit it out into the bloodstream to be absorbed to fix the hypoglycemia. Ordinarily, the liver and the pancreas work as a seesaw to manage blood sugars in somebody that does not have diabetes. The pancreas puts out the insulin to fix the higher numbers from eating or stress. And then if a little too much was pumped out, the liver puts out glucose through gluconeogenesis and puts it into the bloodstream. And then it's a balancing act. That's hard to get when we are injecting external insulin. And so we have to help in emergency situations, whether it's simple carbs or the glucagon if we get drastically low. We now have Baqsimi. Baqsimi is glucagon powder that's put into the nose and rescues the blood sugar. All the same side effects. Some nausea could happen, maybe a little vomiting, just kind of feeling off once the blood sugar is fixed because we got so low. If the person was passed out when you use Baqsimi, you'll need to put them in rescue position in case they vomit or they're not well when they come to. Gvoke is a pre-mixed type of glucagon. It's already mixed in a syringe or the pen, and I have two examples of it here on the slides. It's about time we have glucagon that's already mixed up. The glucagon red emergency kit is the traditional kit that we're all used to, but it's stressful and it's scary and intimidating to have to teach and administer in an emergency, let alone teach your college friends and roommates how to do it if you had to administer it, or somebody on a field trip with the child at school. So we're so happy to finally have pre-mixed versions, and these versions will go into integrated pumps down the road that will be working with insulin, glucagon, and a CGM, a glucose value, to manage and do everything almost completely hands off. So it's great to have these other options available. The red kit for glucagon will be coming off the market very soon. Whatever the pharmacists have, once they're down to the last red kit of glucagon, it'll be gone. So the other versions are what we'll be using most. Severe hypoglycemia, my face when my blood sugar will not do what I want it to do. We have all been there. We have all had one of those days and times. So these are all just the rescue positions for when you need to give glucagon, mixing it. We do want to administer some food when you do have to give glucagon and the child has come to, a little something easy on the belly, because we also want to sustain the blood sugar at a safe value once it's come up. For whatever reason it drops so low, we don't want it to get back there. So I always advise, we always talk about giving additional food or snacks to calm the stomach and keep the blood sugar sustained. We do teach that families can call the doctor on service to get some extra help or direction if they had to use the glucagon kits. They can also wait till the next day if there's been no injury or no awful emergency or seizure that led to any confusion about what was really going on. Was it a seizure from something else versus a hypoglycemic seizure or something? They can call 911 also to get more immediate hands-on help to assess vital signs in the situation, make sure things are okay. So high blood sugars. Hyperglycemia with ketones and without ketones. So no matter what, the signs and symptoms include the polys, polyuria, polydipsia, polyphagia, could be bedwetting, fatigue, drowsiness. I do see that sometimes younger kiddos get a little high strung or hyperactive when their blood sugars are high. They're just disoriented and on edge. It just depends on the kiddo and the situation. And then ketones, the symptoms and the signs you would see for ketones, some vision changes, the nausea, vomiting, very, very dehydrated. Hopefully we don't see any of the awful signs of dehydration, or the ketones have been there for a much longer time. Kusamal respirations, unconsciousness. Unconsciousness could happen in an awful case of diabetic ketoacidosis. Maybe at new onset, maybe even in a case of worrisome non-compliance. The causes for the high blood sugars kind of flipped from the causes of the low blood sugars, very different extremes. Missing insulin, forgetting it, meaning to take it for a snack or food dose and then forgetting it. Maybe because you didn't take the insulin before we ate versus you took it after the couple of bites of the meal, and the sugar from the food hit the blood first and we got high. And then finally the insulin kicked in 20 minutes later. And so we're high before we actually stay stable. So the high blood sugar could just be the rebound that happens from eating. And maybe indeed it'll come down eventually on its own. It could just be we need dose changes. We need to change a ratio to get more insulin or a little extra Lantus dose. Missing the Lantus dose, missing the Lantus almost always causes hyperglycemia kind of across the board, baseline all day. And we need kiddos to figure out a plan with regards to correcting every couple of hours to make up for the missed Lantus insulin. Or sometimes we split the dose and give half of the dose in the morning and then the rest of the dose in the evening and get back on track the next day, knowing that numbers will be a little off for that 24 to 48 hours. Insulin leakage with insulin pens and syringes. You might have insulin seep out and nobody knows how many units actually comes out of the leg or the arm whenever we inject insulin. That's why we like our families to count to at least 10 before we take the needle tips out, hoping everything stays under the skin. Over-treating lows. I don't know how many times I see families just honestly nervous and worried about the low blood sugar or the symptoms of how awful their son or daughter looks. I know how I feel when I'm low, and sometimes I just want to eat an entire sandwich, even though I just had dinner, right? Like, it's unfortunate, but then we could just rebound the other direction and have a very high blood sugar that you didn't mean to have happen, but we were treating the symptoms of how we felt. If we eat more than we need to fix the lows, I would advise families to eventually take some insulin for the extra, the overage. So if you treated with 15 carbs and the blood sugar eventually came up, but we still felt kind of crummy as the body got back on track, you should dose for whatever additional stuff you might eat. Honeymoon being over, needing dose changes because pancreas is no longer working at all. Bad insulin, expired. It was in the sun at the beach or froze in the car. Hopefully not. If we're not exercising or active, we need more insulin. If we're gaining more weight, we might need more insulin just to match the body surface area. The hormonal changes, growth hormone, puberties, starting in the adolescent period, we do need to match up with more insulin. It's not okay that we're high high, like off the chart hyperglycemia all the time during these stages, but I would expect some subtle highs that just takes more corrections to try and fix, which then identifies the need for dose changes to prevent it from happening in those the periods of adolescent growth and development. Didn't get to insulin pumps yet, but insulin pump therapy, your sites could peel away, they could kink up, fall off, the technology could break or malfunction, and then quickly we're going to have a high blood sugar and need to find a way of fixing that and getting things back on track. Ketone strips and blood ketone meters. So ketoacidosis is hyperglycemia, ketonemia, ketones in the blood and in the urine, and metabolic acidosis with a low pH. Life-threatening, could lead to an ICU visit, hospitalization until things are stabilized. We have to slowly rehydrate our kids with DKA, because if you go too quickly or we don't treat it all, we could have significant cerebral edema, diabetic coma, and ultimately lead to death, which is very, very scary. So that's why we need to get these kids safely in and treated and managed to get them back on track. It's not a quick fix. You need the hydration for the insulin to work when they're so dehydrated from the hyperglycemia. So it's a slow process. In digits or numbers greater than 300, I would expect that we could, not always, we're not going to have ketones, but usually greater than 300. DKA consists of blood ketones greater than 3 millimoles per liter. And then the acidosis part with the pH will be less than 7.3, or the bicarb will be less than 15. Signs and symptoms, a little bit more of. The labs, when we see our families, patients in the emergency department, we're looking for glucose, the osmolarity, sodium, potassium, bicarb, pH, BUN, all looking for the acidosis signs and what's going on. There is the blood ketone meter. Maybe many of you have seen before. Love this version because it's a more accurate version of getting ketones tested. And getting a digital number read. The little color display, the red light on the left-hand side tells you the digits for when to not be worried about ketones and when to start worrying about ketones. And knowing that urine, when it's sitting in the bladder, it could be there for a bit. So sometimes if there are ketones in the urine, it could have been slightly old data. So I love that we have these meters. Not everybody has them. They're not always covered by insurance, or they're hard to get at the pharmacies. We do what we can to get them for the infants, the toddlers, the little guys that have a hard time peeing, as well as our pump kids, just because of their higher risk of possibly having ketones on an insulin pump. What we teach our families to do for kind of reversal and management, checking for ketones, however they have the device to do so. Strongly encourage that they are drinking their water to hydrate enough every hour, depending upon their age and weight, of fluids to help them to hydrate well, and correct insulin. We correct insulin when ketones are present every 2 hours instead of every 3 hours. We know that our rapid acting insulin lasts for 3 hours, but whenever we're ketotic, we are resistant to insulin and need more of it. So as we hydrate, we need to correct, and we offer the corrections every 2 hours, and sometimes more insulin, like 20% more. If a child is vomiting such, or they are unable to drink at least 8 to 12 ounces of water each hour, moderate to large ketones, they're going to probably need to get into an emergency department or get something, whether it's, we sometimes consider Zofran, and other times we worry that Zofran will mask the signs of DKA, because all of a sudden the vomiting will stop, and we might not remember to keep hydrating or drinking or taking the correction insulin every 2 hours. So we're okay ordering Zofran. We're just looking for a good communication there on how to continue to follow up on sick day management if indeed the vomiting suddenly stops. What happens next? And if it continues, they obviously need to come in for IV fluids and possibly an ICU visit. I usually do most of my talks in person, so I'm always like looking for hands and questions and answers. So I would say I'm here to answer questions all the time, but obviously I'm under the impression I will do most of that at the end. At this point, I was going to switch over to type 2 diabetes because there's been so much of an increase in that in the most recent couple of years. And then I'm going to go on to talking about insulin pumps. I see there's a question, but I believe I should just continue and go to the end. Kimmie?
It's up to you.
I guess I'll continue. I have no problem getting through and then doing the questions at the end, just to try and stay on track, I guess.
Sounds good, no problem.
All right, so type 2 diabetes. Type 2 diabetes is a disorder with a combination of insulin resistance and a defect in insulin secretion with a very strong, heavy genetic component. It's typically found in overweight children, and there is a much higher incidence in African Americans, Latinos, and Pima Indian nationalities. The signs of their hyperglycemia are very similar to what we see for type 1 diabetes. The fatigue, increased urination, thirst, the hunger changes, but it's not rapid. In type 1 diabetes, these signs and symptoms of type 1 diabetes occur very fast. And by very fast, like within a couple of months, there's a big problem and we know our kiddo is sick and needs help. For type 2 diabetes, it's a slower evolution. It takes a little bit more time often. And so the symptoms become more adaptive and not as easily picked up as unusual. The acanthosis nigricans is that thick, velvety, dark skin noted in areas of skin fold that rub. So it could be the axilla, the underarm, groin area, behind the kneecap or elbows, definitely behind the neck though is a very common place. And that is a very ideal sign, a classic sign of insulin resistance, meaning the body is trying to make insulin and it's just not working. It's resistant to what it's supposed to be doing. Eventually, insulin resistance, when the body's trying to put out insulin to help blood sugars, but it's just not working at the cellular level, leads to a decrease in the body's ability to make enough insulin, and could then lead to the need for type 2s to be on insulin injections. We're trying to phase away from that though with the newer versions of medication available. Metformin is the only oral medicine FDA approved for type 2 diabetes in the pediatric and childhood population, which is what I work with. So the metformin and I get along well as prescribing it to children as needed. There is a side effect of the belly aches, crampy, diarrhea, bloating symptoms with metformin. But if kids and adults stay on it enough time consistently, those they get used to, and those signs to sort of reduce and lessen. Newer medications available. We're so happy to have newer meds available that are now FDA approved for a pediatric population. GLP-1 inhibitors now improved in the pediatric use. There's more information coming on them, but they are wonderful in how they reduce the amount of glucose being made from the liver, kind of slows that down, helps the body to get a little fuller faster, slows the absorption of the food from the gut because of that. And so then things slowly push out into the bloodstream, little less hyperglycemia in time, a little less eating in time. So possibly some weight loss will occur. And we like to use these GLP-1 inhibitors along with metformin together. They have a very good additive effect. In the past couple of years, we have seen the number of type 2 diabetes diagnosis in the United States rising over 77% during that first year of COVID, which is amazing when you compare it to the previous couple of years before COVID pandemic happened. The average patient age was about 14 and a half years, give or take. 50% were girls with type 2 diabetes, 40% were Hispanic, about 32% were the Black or African American population, and 14.5% were white Caucasians. A few patients were also diagnosed as having COVID-19 at the time of the hospitalization from a Johns Hopkins study that I had been looking through. BMI for these kiddos were all greater than or equal to the 85th percentile, meaning they were overweight. in comparing and contrasting type 1 versus type 2, I've echoed a little bit of this already, but with type 1 diabetes, almost 90% of them have antibodies. So antibodies in the blood show us we are assuming that the body, at some point, the immune system will attack the pancreas and prevent it from making insulin. The body will self-attack the autoimmune system. Type 2 diabetes, there is typically not an antibody present at all. There's 4 antibodies we look at, and any 1, 2, 3, or 4 of them can be present, and it's type 1 diabetes. With type 2 diabetes, almost always they're negative. Once in a while, we have like a mildly positive GAD65 or something's just a smidgen positive, but then all the other signs of type 2 diabetes. So we have to treat with insulin if we have such hyperglycemia and such elevated hemoglobin A1Cs to start, but then really review the rest of the system and the body and how the patient's doing to see if there's a way we can wean them off of the insulin depending upon antibody status. Type 1s do not have acanthosis. Type 2s will or can. Type 1s, when you admit them, if you were to draw a blood insulin level, it will be 0 or low, not there at all, because their body's not making it. Whereas type 2s, it could be very drastically elevated, very high insulin level, but doing nothing, and the blood glucose level is also elevated. It may also be low and non-existent if the pancreas has tired out from trying to overcompensate with insulin. The type 1s will not be overweight. Type 2s likely will be. And the symptoms are drastic with type 1s versus slow and gradual with the type 2s. The road to type 2 diabetes. So looking at pre-diabetes versus actually having type 2 diabetes and where our hemoglobin A1C values and glucose values should be. A lot of this also depends on the lab that we're having blood work done at. But normal hemoglobin A1Cs are around 5.5, 5.7 or less. Pre-diabetes is anything greater than about 5.7 up to 6.4. And then type 2 diabetes diagnosed greater than 6.5 A1C. Fasting glucose levels over 126. And then after a glucose challenge, blood sugar values that are over about 200 after having glucose. At Nemours, I'm so excited to say that we have a type 2 diabetes clinical pathway that we have created. Wonderful nursing staff and dietitians put together to help with the high incidence of type 2 diabetes. We have posters and presentations that we've done on it, so we're very proud of this, and we've added, modified it through the years with the new medications that have been approved. We try to keep our type 2s off of insulin as much as we can. Should the type 2 patient need insulin at diagnosis, they will begin with a basal bolus regimen along with metformin. So like a Lantus and a Humalog insulin along with metformin. Once we make sure liver function tests are normal and everything is good. And then we do weekly triage where we have a dietitian and our diabetes educator weekly talking on the phone with the families or doing a telemedicine visit to chat through blood glucose values, medication compliance, how their bellies are feeling with everything to see what to optimize or change next. We do our best to get them on a GLP-1 medication as soon as possible, along with metformin, and hopefully wean them off of insulin altogether. The GLP-1 glucose-like peptide receptor agonists could be either Victoza, Bydureon, Trulicity, and now we have Ozempic. Ozempic is all over, but probably low demand or not as easy to get. But we do what we can to get appeals and authorization when indeed we need to get the medicine ordered for the children. And hopefully providers do the same thing for the adults. Because they help to slow the stomach's gastric emptying, they increase insulin production to reduce the glucose release from the liver, hoping to keep things stable without needing any insulin injections. We've done well. We've done well getting a lot of these patients off of insulin, but at the same time, sometimes the population is harder to get to appointments, to have the phone calls and the pathway program attended. So we do what we can. We also have the Healthy Weight Clinic, who does great with psychology and dietitian, exercise physiologists, nurse practitioners, and doctors to work as a team to help with goals, to help patients with their weight reduction. And they can do gastric bypass surgery. I just had a kiddo, a young adult, have surgery this week and already on significant less insulin. So that's great. So type 1 and type 2 diabetes, if they're on insulin, we can get them approved to have a continuous glucose monitor, which is unfortunate given insurance rules and things, but almost all of our type 1s are now able to get a continuous glucose monitor. There had been through the years significant difficulty getting these monitors for some of the insurance plans out there, but we're definitely in a better place. And definitely watch the Super Bowl this weekend. I'm sure all of you will be. But Nick Jonas will likely be doing another commercial with the Dexcom G7, which will be launched this week, a little bit sooner than we originally thought. But it'll be a great CGM, lots of benefits and pros to how it operates. So it's great to have these tools at our fingertips. Continuous glucose monitoring systems provide real-time blood glucose estimates about every 5 minutes or every 1 minute for the Freestyle Libre, the newer, the other CGM version. That is hundreds of blood sugar glucose values or blood glucose values daily. Fabulous ways of seeing our numbers from wherever we are, whether we're home, whether our children are at school, sports, out running, whatever's happening. They provide more than just a single spot check of a blood sugar because they give us arrows on where we were and where we're going, a noise or an alarm for upcoming low or high blood sugar values. The warnings are there, and if we have the app open in the background and connected to family members to follow us, we should be able to stay on top of and hear what's going on with our numbers and stay safe. It minimizes the guesswork and allows for more activities to happen with children doing different sports, doing sleepovers, possibly field trips, or going out and about, because there's better ways of communicating about where the blood sugar values are and feeling comfortable giving the full dose of insulin when the blood sugar says 102 and we know we're about ready to go for a hike. Is it 102 and flat and stable, or 102 with the down arrow dropping? Classic, looking at a blood glucose meter and seeing the blood sugar is 105, kind of what I just said before. We don't know where we're going. If this is bedtime and we have nervous mom or dad not wanting this blood sugar to go low in the middle of the night, they might want to just give a little something to eat, which would force the blood sugar up a bit. But is it needed? When you look at the CGM value below, this example shows you on the phone, the blood sugar is 105, but dropping, the arrow's moving down. So I see the slope, I would think differently and want to treat with some glucose, a little something, because the blood sugar might be greater than 100 for bedtime, but it's dropping. So at some point I would worry that we might have a low blood sugar value. Kind of a pictorial. This is looking at the Medtronic MiniMed glucose monitor. It had a great example of how it looks sitting on the skin. You can see the skin, the sensor glucose sitting just in the interstitial fluid, close to the blue cells. You can see the red drops of blood in there, the glucose values, and then the blood vessel down below. So the blood vessel, the sugars leave the blood vessel, enters through the interstitial fluid, and then will go into the cells when insulin opens the door and lets the sugar molecules inside. So there's going to be a little flux or change in the glucose value accuracy on a blood sugar stick on a finger stick meter versus a sensor value because of where the sensor cables are sitting versus a blood sugar finger stick value. They're not always going to match. They're pretty darn close, and they're going to be even closer in the newest Dexcom CGM coming out. They're amazing, and they're at the point where you can rely on them to help your insulin pump to make educated decisions on what's going on. So, but just know that they might be off by a little bit, or they might be off by a little bit more, depending upon rapidly changing blood sugar values Or maybe if we're squishing the sensor at night, I don't know how many times I've been like lying on it funny and it went quickly low. And once I rolled off of it, it popped back up again and went back to where it had been. So there's things that we learn and little nooks or little tools that we know as to how to keep these things working well and really assess what the value means and what's going on. So this is the Dexcom continuous glucose monitoring system, the G6 system on the left side. You can see it on the phone and the receiver, the watch, and then the Freestyle Libre with its data that it's giving on the phone as well. The little tiny circle Libre and how it reads, both of which read very well and do a very great job of giving information to family who want to follow the sugars, friends, teachers, school nurses, all of that, to keep everybody in the loop on what's going on. So here is a review of a blood sugar Dexcom graph. When we see kids in clinic, we get a code to be able to pull up all their data and see their blood sugar values. So this is an example of a review that we see to give us a heads up about blood sugar values for children over a couple-week period of time. It has an average glucose value, a predicted hemoglobin A1C in it, and then it has like the time in range, how much blood sugar values have been in range versus high or low. We like to see, and the standard that we're looking for is that blood sugar values are in range close to 70% of the time, hopefully without drastic lows or drastic highs. There are times that I see the in range in the 70% range, but then the blood sugar values for the child might be up and down and up and down. So as much as an A1C might look okay, the time in range is not ideal if we're rising and falling. That can't feel good on the body and is not safe on the blood vessels. So we go then and move to some of the other reports that show us the average graph of everything. The Dexcom version, as does the Libre version, will pull out the times where there's more lows and more highs. So there's some lower numbers in red we can see on this chart, closer to 6, 7, 8 p.m., a little bit in the morning period time, 6 a.m., 8 a.m. possibly, little rise in the evening, probably after dinner happening here. And then this is a breakdown of the individual weeks with each color line as a different day of the week. And I can look at lots of other charts in here and graphs to pictorially review each individual day and what happened. There is a way on Dexcom to enter in carbohydrates eaten and insulin doses for more complete record keeping versus the writing down carb, insulin, blood sugar, stuff like that. There's a way of storing it in here so that we can see it and add up insulin doses and stuff throughout the day. But this is a wonderful way to consider making dose changes and help children with their activities, their sports, their, trips, outings, weekends versus weekdays. Here is another review of a continuous glucose monitoring system. This one has an average glucose of 176, a predicted hemoglobin A1C or GMI glucose management indicator of 7.5, time in range says 53%. Minimal lows, less than 1% low. There are some higher numbers. Looks like the sensor is always on. The days that it's used is 100% of the time. I'm seeing pretty stable overnight blood sugars. When you look at midnight through like 6 a.m., everything looks fabulous, like pretty steady sugars overnight. Love it. Then there's breakfast. I would say maybe we need to dose for breakfast a little bit earlier or make sure that this person has a little more protein in breakfast. Even eating the protein first for breakfast can buffer the absorption of carbs. So maybe dosing for breakfast as we're getting dressed in the morning, eating some almonds or cashews or even a tablespoon of peanut butter. And then by the time you get downstairs, starting to eat your bowl of cereal or your yogurt and fruit or whatever it is, so that possibly you don't have such a high rise after that breakfast meal. It looks like we kind of come down into range a little bit by 12 noon, closer to 140, 150, and then a little bit of a lunch rise that just sort of strolls there throughout the afternoon, close to 180. So maybe a little more insulin might be needed for lunch, a different ratio or something. But like, this is fabulous because it's all right here versus having to pull information out of a blood glucose meter or download it and try and put together where the low, high, and in range numbers are. This is a review of the Libre, the Freestyle Libre CGM, and what we see. Same thing with time and range. So this is a projected average glucose of 145. The time and range is at 81%. So this kiddo was doing fabulous. He had the wrong date on his thing. It was like, it was years in advance, but it was the most real data. And then it gives us predicted hemoglobin A1C for the Spella at 6.8. Here's those graphs with the little plots of the average glucose values and where he's sitting in his time, overnight, afternoon, morning, etc. And then we will go in to discuss a little bit about insulin pumps and the integrated systems. I will show some charts to show you what we see when we download the data. And we want to know this sort of data with everybody, even the ones on injections. We want to know how much insulin they're using. We want to know like the amount of insulin they're taking for breakfast, lunch, dinner. But for pumps, it's all a tool that can be downloaded. And so we have access to all these charts to be able to see the answers to the questions we would ask. So different insulin pumps, we know that a pump is a method of delivering insulin. It very closely mimics the way our pancreas would function and put out insulin for higher and lower blood sugar values. We know it's likely a small device, probably connected to a tube, and then a site on the skin. It's worn outside of the body. These ones are not inside the body. There are pumps with tubing and pumps without tubing. For pumps with tubing, the insulin flows from the cartridge in the pump through the tube that was primed, and then into the skin through a little catheter, and it's taped on a small little patch. And there could be a catheter under the skin, or there could be a little needle that's left under there. Probably 85% of the time it's a little catheter versus the needle. Then there's also the pod, insulin pods or Omnipod. The pod contains insulin inside of the pod. There's no tubing, but there's a separate receiver device or possibly a phone that which you use for settings and dosing. There's no outside tubing. The pod is Bluetooth and learns your settings and gives the background insulin on its own. Every pump, the sites on the skin should be changed every 2 to 3 days, definitely 3 days max, so that the skin's all right, the absorption of insulin is safe and healthy. Insulin's had only been allowed to stay in the tubing for so long in the pumps and the reservoirs. There has been approval now for insulin to stay a little bit longer. So that's changing, but I can't even keep a site on for that long half the time, like it'll peel away or something. So we need to focus on changing our sites for the well-being of everything every 3 days at least. The fellow on the left, he has one of the first insulin pump prototypes that was created back in 1963. This was actually supposed to have insulin and glucagon in it. It was a backpack type device, and there was a whole bunch of tubes and catheters on his arm. Wouldn't be wearing it, wouldn't be running a marathon with that. But look where we've come. Right above is a smaller version pump, still having a reservoir or the syringe with the insulin on the outside, and the large tube, big button pushing, and then another smaller pump, the old Animas insulin pump down below. So it's great to see, absolutely great to see the way that technology has changed diabetes. No, we've not cured it, and we're getting there. We're trying to prevent the evolution of it and stop it from happening in the patients that have antibodies. We're trying to control it with great technology, better glucagon and insulins. But it's amazing to see how things have improved. And that to me is delightful. And it's just satisfying. It's amazing to see how technology and medicines have changed. So I love it. Basal and bolus insulin. So the kids and adults on injections, they take Lantus or Levemir, Tresiba, that's their basal. And then bolus insulin is the Humalog or Novolog that's rapid acting. For the pump, it's all the same stuff, but there's no more background long acting insulin like Lantus or Levemir. They're just going to be injecting rapid acting insulin 24/7 in small increments via the insulin pump. So a little pictorial of basal insulin versus bolus insulin. So we can see the continuous infusion of insulin into the fatty tissue that happens with the basal insulin running day in and day out. And the little line at the bottom is the basal or background insulin, with then larger peaks of bolus insulin for breakfast, lunch, and dinner. The small little picture on the right is a picture of the Omnipod receiver with different basal settings based on the hour of the day. So you can have various basal rates, various units of insulin on various hours of the day. You could have 24 different basal rates. You could have 2 different basal rates. The example I like to give is that we're trying to meet the needs of our body. Certain times, like overnight, the body is growing, and by morning, dawn phenomenon, waking up, extra cortisol comes out. So a lot of times we need more basal insulin in the early morning hours, a little less by afternoon with activities and such. So we just try to meet the needs of the body the best we can. But the pumps that are integrated with continuous glucose monitors learn even better and kind of do it for us to a small degree. Yep, there we go. Here's the basal rates, different hours of the day. If a kiddo is disconnected from his insulin pump, it's taken off, or it's the tubed kind connected to a pump, worn on their belt or the pocket or somewhere in their pants, and they disconnect. Ideally, we need to make up for some of that background insulin if they've been disconnected for close to an hour. If it's only been a few minutes, or a shower or a bath in the morning, 10-15 minutes of missed basal insulin shouldn't be any alarm or big deal. And if it's close to a meal and you were going to bolus for dinner or something like that, then you have some extra bolus insulin on board from the food to make up for whatever basal was missed. But we don't want to miss too much basal insulin, because at some point we might expect some gradually elevating sugars to occur. Even those that are exercising, I don't like to see they disconnect for too long, because they might be exercising and at risk for low glucose values. But at some point, if they were missing basal for like 2 hours of a game or a sport or an activity, at some point their body's going to realize they didn't have insulin, and it might start breaking down the stores of fat or muscle for energy, which exercise actually worsens, and they could develop ketones from being active and not having insulin to get the glucose molecules where it needs to be. So delayed highs could happen with exercise. So I don't want to see somebody without the pump for too long for sports. We have good plans of bolusing missed basal or something if they have to disconnect. We don't give the long-acting insulin. I've had a couple of families they did give long-acting insulin, or they had like a combo plan happening. That's rare, doesn't happen often, especially with the integrated pumps. But there's all kinds of ways and methods for managing diabetes, and we've learned so much. So it's great to be challenging and creative, but safe in our ways of handling diabetes to help meet everybody's needs. Food. So bolus insulin taken for food using the ratio and correction factor programmed into the insulin pump. And they also have fancy ways of extending boluses for high fat meals, or doing some different things to keep boluses for certain foods more ideal. So ice cream meals versus, a salad type meal, we can administer the bolus insulin slightly different. In an insulin pump, we program the duration of time that insulin lasts in the body, which is close to 3 hours. And the pump will use that to calculate how much insulin's on board or in the body to allow for additional corrections to be given for possible high blood sugars. So the pump does all of that math on its own, versus we tell kids on injections, don't correct but every 3 hours, unless you have ketones, then every 2. And, we could help them figure out that math, but we just play it safe and say every 3 hours you could give a correction. But the pump could sometimes even give a correction a little sooner, but a much smaller dose based on how much insulin it recognizes had been used up since the last bolus. The active insulin time or insulin on board time helps to provide that small extra insulin without stacking it and leading to hypoglycemia. So we don't have like bolus rage when we're high and we bolus to fix it. We don't want to be high. We want the kids to come down, but we want them to listen to the pump's calculations because it'll look after them and prevent overdoing a correction that might lead to low blood sugars. Here's a kind of a finagled example on a Medtronic MiniMed insulin pump where we see that, well, a couple of things are happening. This one here is giving a negative correction. So regular corrections for high blood sugars are when we give extra insulin to bring down the blood sugar because it's high. And then a negative correction, the insulin pump might subtract away insulin because the blood sugar is low. So it would put a low blood sugar in the correction formula and do math that turns into a negative number, and then that gets subtracted from the food insulin dose. So here it has like a correction formula for minus 100 divided by 50. If the blood sugar value in the bullet point says it's 300, 300 minus 100 divided by 50, 4 units of insulin. But what if the child's blood sugar is 60? You could treat it with carbs, and probably in that case, don't tell the insulin pump the blood sugar was 60 because then it will double do. You'll treat with carbs and the insulin pump will take away insulin. If we're only in the 60s, low but not too low, and dinner's on the table, I will often say, go ahead and put the 60 in the insulin pump and watch it negatively correct you. So 60 minus 100 divided by 50 would be negative 0.8 units. So the pump would then subtract that away from the food dose. So it looks like 60 carbs divided by a 1:10 ratio is 6 units for food. You do the math, and then it turns into only getting 5.2 units of insulin because the blood sugar was lower. But in this situation, I wouldn't give Skittles or juice, knowing that dinner's on the table when we're going to start eating, maybe even start with the carbs first. The pump's going to take away insulin. I wouldn't do both. If we're less than anything in the less than 60, I would say we need to treat. I don't want to see that we get too low or too confused waiting for dinner that could have protein in it to fix a low blood sugar. So this is kind of a sensitive kind of area that we have to talk about with families to figure out what makes the most sense. But just FYI, the pumps are smart and they're thinking for us. Different insulin pumps. And I have almost all of what's out there now. I have the older Omnipods, the Eros, which will be basically discontinued soon, the Omnipod Dash, the Omnipod 5. So the bottom row are the ones that are out there now, the latest and greatest. The Omnipod 5 integrated with Dexcom, Tandem with Control IQ integrated with Dexcom, and then Medtronic MiniMed 770G. They have their own continuous glucose monitor, the Guardian. And so it's not with Dexcom, but it has the Guardian CGM patent to Medtronic, and having auto mode capabilities, just not with the Dexcom CGM that we're kind of used to. So Medtronic MiniMed's hybrid closed loop insulin pump with the Guardian sensor. It uses auto basal to increase and decrease to help to keep blood sugars more stable. For Medtronic MiniMed, you need to calibrate the sensor to make sure it's working well. So that means you finger stick on a meter, see what the number is, and enter it into the pump to help the Guardian CGM work best. And you have to do that a couple of times a day to keep it working properly. For the Omnipod 5 and the Tandem insulin pumps with Dexcom, you don't have to calibrate Dexcom, so you don't have to calibrate the systems to get it working. I guess a little bonus there when you're thinking about the whole thing. But choosing an insulin pump, I honestly say it's like buying a car. You really have to find what works best for you and the family. There's no right or wrong. I'm not going to go out and say you need to be on this pump or that pump. I want each family and parent to really try and listen and hold and look and touch and feel each of them to see how it might fit into their lives. And to know that you can always change. It's just going to be a few years likely until you switch pumps to something different. Usually there's about a 4-year warranty for an insulin pump, but we're getting closer and closer to having these supplies as pharmacy benefits instead of durable medical benefits, which allows us to get them new ones quicker. So it's great to have that ability. This is the Omnipod 5, FDA approved last spring and summer out on the market. It has Dexcom in it. It does work on an Android or some of the Android phones. And if you don't have an Android phone, you get this receiver, the device that you can use, and it helps to bolus you for it and get your insulin in and all of your settings. The Dexcom sensor and the transmitter talks to the pod about blood sugars. It tells the pod what's going on, and the pod, the little device that holds the insulin, will then determine how much extra insulin or less insulin to give to keep blood sugar stable. The receiver or the phone can be wherever. You don't have to be close to it to get your basal insulin or to have the auto adjustments done. But you need it to bolus for food, so you can't lose it. Can't wait until it's all in one on even the iPhones, but slowly but surely we'll get there. I won't go into many of the details. I want to save some time for questions about each system and how it works. Here's a great review of like what I see when I look at charts and downloads of data for time and range, insulin being used, how much insulin is being delivered as basal versus bolus insulin, how long is this child in automatic mode where the Dexcom and the pump are talking to each other and helping to keep things stable. We see carbs per day, like how much is eaten, all kinds of great detail. And some of the blood sugar values you can see pulled in from Dexcom in that AGP chart down in the middle. This is a nice review of the dailies of what we see with Omnipod when boluses are given for food, the carbs, the insulin doses. The little red bars might tell us when it was suspended because blood sugars were lower and it wasn't giving insulin. All kinds of great data in here. It's great to see when it's giving max basal as much as it can give, or zero amount of basal units. Great data. Here's Tandem with Control IQ using Dexcom insulin pump. Tandem does have tubing. It has an app that can be put on any phone to help with bolusing. So you do have a pump and you're stuck to the pump on your pocket or in a bra or wherever you want to put it. And you use the pump to dose and do all your settings. They have their app has the bolus feature. So you can bolus on your phone, but you can't do everything else on the phone yet. That's coming within hopefully the next year or so. We'll have the next version, Tandem, the T Sport, and it'll be 100% operated on a phone. But for right now, we can just bolus from the phone, which is pretty darn good, I think. And it also uploads the data from the pump. Tandem's Control IQ will do more than the Omnipod with regards to insulin because it can also bolus. So it can do small extra boluses as needed in a safe way, a safe calculation on its own, and extra basal or less basal to keep blood sugars stable. So a little different. Omnipod can give basal more frequently, but then Tandem can do little bolus settings. Again, we can make the systems work for the child or the adult. It's just a matter of what they prefer to have with them and on them. Different settings on Tandem's insulin pump for different adjustments, going for exercise mode with a slightly higher blood sugar target that it's shooting for, or maybe not exercise mode, regular mode, where it's shooting for 112 to 120. So different settings and adjustments we can make for Tandem. Downloaded data. Here's a Tandem chart. I did all kinds of highlights on this one. The little Dexcom at the bottom down here shows some erratic blood sugars with food, quick to absorb carbs and rising blood sugars. Overnight numbers look pretty stable for this fella. One night was high, the rest not too shabby, but just ups and downs with food. The one thing to remember with these integrated pumps is that if we're not dosing for what we eat timely or early, the pump will start to give extra insulin to realizing that we're getting higher, something's going on. And then if we dose for the food 10 minutes after we started eating, there's a big chance of a quick high and a quick low because you've dosed fully for what you ate, but late, and it was already trying to pump some extra insulin to fix the problem. So I can see for this patient around 3 p.m. he was getting low, and maybe we weren't pre-dosing enough for lunch or something. I highlighted all the times it was giving extra basal insulin or little boluses on its own versus when the child was putting the data into the pump. So for school nurses here, we talk about insulin pumps and like, what does it mean for you and what you see and what's going on in the school setting. I know at Nemours, we always provide our school letters and our data with settings and doses and devices for specific to each child. We do want you to always follow those orders from the patient's provider. Use the parents to guide your dosing and decision-making. If we said in that letter that they have been trained and we feel that they are competent in order to give you the final say, Jimmy's having gym today and he's already low, let's take off a unit of insulin. Like, that's absolutely fine to listen to the family. And I hope you have the ability to fill them out and be comfortable with that decision. I know there are some nurses that need us to make the final decision, and that's in the letter. You have your own ability then to just listen to what's on the letter as far as the ratio and correction factor or the pump settings and just doing what it says. Or we can get very specific about what the letter says if we need to. For pumps, listen to that bolus calculator. The pump recommends the dose, and when you override it often, then we don't know what's really going on and how to make changes efficiently to help situations. We always want kids with insulin pumps to have injection supplies handy, maybe even an additional pump site, whether that means mom or dad comes to school to do a pump site change, or they talk to you on the phone about how to inject insulin to fix an emergency before they come to school and pick up the child to fix everything themselves. It's always good to have that backup insulin injection means in case the pumps were to break or malfunction or something happened. Ketone supplies, all that good stuff needs to be at school. And you can always call with questions. Thank you and questions. So whatever the questions are, I'm here for as much time as you guys have to listen to me.
Great. Thank you so much, Kimmie. I learned a lot. That was a great presentation. We do have a couple of questions in the Q&A that I will ask. And if anybody else has questions, please keep typing them in. So the first question, this is the one that you saw back after your type 1 diabetes section. What about ketones when the blood sugars are at target 90 to 120, not starvation ketones?
So the question is what to do, I'm guessing, whenever there's ketones present, but the blood sugar is stable. That tells me we need to eat and get insulin in there. If there's ketones present and it's enough that we're concerned, hydration for sure. And then we need to get food in the body that we can correct and get insulin in, because the insulin is what's going to help to get rid of the ketones. That could be a time where there was lots of exercise happening and either suboptimal food or carb intake, something along those lines, or vomiting and blood sugars are in range versus high. But we vomited the food, we're stable, but we're not eating anymore. So the body's breaking down fat and muscle and the ketones are present. We need to get food in there. It could honestly be like Gatorade with carbs that we're dosing insulin for, regular ginger ale, depending upon the situation and what's going on. If it's an athlete exercising with starvation ketones, then it would turn into getting good energies in there and making sure that our athletes eat good nutrition throughout their workouts. And that we figure out a balance to when we need to give them insulin to absorb it better versus have the ketone formation.
Wonderful, thank you. And I have one more question in the Q&A. And again, folks, keep asking any questions as they come up. This one was more towards the end here. I know the Dexcom G6 has about a 20-minute delay as compared to a real-time finger stick. However, it should not be a 100 to 150 milligram per deciliter difference, correct?
Yeah, correct. It shouldn't be that much. That's pretty big. But do know that during times of rapidly changing glucose values, if the blood sugar is rising high and we're 350, you could expect 15 to 20% difference in the finger stick value. So say it's 20% and the blood sugar is 300 or something, that could be 60 points off. So like 360 to 240, not 150 points. 150 points is a little concerning. Hopefully nobody's trying to falsely calibrate Dexcom to a different number or something like that. Maybe the sensor's bad, maybe the site's not doing well, maybe the transmitter battery's dying and picking up a poor signal. But this should not happen consistently. If it's a 1 or 2 time thing here and there, it should be very minimal if that were occurring, that it was that discrepant.
Thank you. Okay, another couple have came in. So if a newly diagnosed diabetic, 2 to 3 years old, has only had a Dexcom G6 for a couple of months and blood sugars are all over the place, is it a good idea to start on an insulin pump?
I mean, I think I can go either direction with that. 2 to 3 year olds have big insulin sensitivity needs. So they need to cover everything they eat because they're so sensitive to the carbs in the foods that they do eat, but yet they need such tiny doses of insulin. So it might make sense that their blood sugars are all over the place. I don't know what's going on with the family or the, how they're doing their, the timing of insulin, dosing early, covering everything. But I have a strong feeling towards getting used to diabetes, the basics of injections and things for a bit of time before going on a pump. But for some of these little guys, they might do better on a pump. But I would have to take the whole family dynamic into consideration there to see if that's the right fit for them. So the answer is not an easy yes or no. It could go either way here.
Thank you. The next question here. I have 2 high schoolers, both athletes, both Dexcom users. Have had a lot of low readings and no symptoms lately during the day. They are both very well controlled, a school nurse's dream. You mentioned lows in the night, most likely positional. Can that affect them during school activities?
I doubt it. I'm more worried about compressing on the sensor site and squishing it such that there's limited blood flow and it gets bad or poor glucose value data and then reads low. I wouldn't expect that during the school day. I mean, I don't know if they're new onset versus, they've had diabetes for a while. Do realize that now with these integrated systems and such, we have more time in range. We're sitting closer to low normal more often at times. So our sensitivities to lows could decrease. So I'll tell you, I might feel completely fine at 65 and then all of a sudden I'll be 58 and my husband's like, hello, where are ya? So it could just be that they're so well controlled that they're feeling normal at lower numbers and then just missing some of those low blood sugar symptoms, which is concerning, but that's also why we have these CGMs to hopefully whistle out and say, hello, you're getting low. I'm glad they're so well controlled. The athletes though, that will interrupt and interfere with their ability to do well with sports if they happen to get low and suddenly miss the earlier heads up of that. So really listening to the CGM bells and whistles is going to be important.
Thank you. And then quick question here. In your experience, what are the best sites for the Dexcom G6?
Yeah, well, there's the FDA approved sites and then there's the sites I say you can use. So belly is great, hips, love handles, upper buttocks, great. I also love to see it on the back of the arms and the upper outer thighs. I would say a lot of kiddos are putting it on the arms, but it was not FDA approved there. Dexcom G7 will be approved there, so that will not be an issue. But anywhere there's some fat tissue that's not going to be easily compressed by the belts, the buckles, the pants, or easily sat on or anything along those lines. Again, it just needs to be in fat tissue.
Great, thank you. And it looks like our other questions and comments are comments that are saying thank you for such a thorough and informative presentation. And I see another thank you here. So thank you so much. And perfect timing. Thank you so much for your time and your really thorough presentation. Again, I learned so much. I'm absorbing it all still. This was excellent. I'm waiting to see if anything else is coming through. I'm going to share my screen with the survey for the folks as I wait to see if any more questions are coming in. I think this might pop your screen off.
I see there's a question about putting Dexcom on the scapular area. There's a huge gap in readings and finger sticks. I don't know that I could even imagine that. That sounds painful, but I would say that's definitely not an approved area unless it has a decent amount of fat tissue. I have had some girls put pump sites or Dexcom sites on chest tissue, but at the same time, we have to be careful with that, and it was not FDA approved. So.
Hold on. So that's a question for me. I can absolutely put that link in. Hold on 1 second. I have it ready to go. I see a lot more thank yous in the chat. The link for the evaluation, which again, you do need to complete by February 28th to get your credit for these 2 CEUs, is now in the chat.
Sorry, Kim White. Yeah, it sounds like a frustrating area. I'm with you.
Okay, so we're right at time. So if you have your evaluation, you are good to go. Kimmie, it sounds like that you're good. If people do have a couple more questions to hang back for a second.
Yep.
Great. So you are dismissed after you, if you have that evaluation link, but if you do have any more questions, Kimmie and I will hang back for a few more moments for Kimmie to answer those for you. I'm sorry, I do exactly what other people do, and I keep trying to call you Kim, and you're Kimmie. That's the same thing people do with my name.
It's all good.
Great. No more thank yous. Wonderful. Thank you so much, Kimmie. It looks like all the questions have funneled out. You answered everybody's questions. So thank you so much. And thank you for your time tonight. We really appreciate it.
You're welcome. You're welcome. Have a good evening.
And I'll hang on just a few more minutes for everybody to grab those evaluation links.